This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. In case you're new to the podcast, I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since 2016. Is that right? Yeah, that sounds right. And we've been doing this a while now. And we try to give you these medical education podcasts just to review different topics specific for hospitalists. So we have been hitting COVID hard for a while, and we're doing some non-COVID related topics. Today, we are doing a topic that is near and dear to our hearts in Pittsburgh, and you're about to see why. We are going to cover Down syndrome and its inpatient implications. And there is no better guest for that type of an episode than the one I have right now. So I'm going to introduce my guest to you. It's Dr. Kishore Vellody. Dr. Vellody completed his medical degree at the University of Illinois at Chicago College of Medicine and his pediatric residency at the Children's Hospital of Wisconsin in Milwaukee. He's a professor of pediatrics here at the University of Pittsburgh School of Medicine. He's also one of my partners in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And in March of 2009, he assumed the role of medical director of the Down Syndrome Center of Western Pennsylvania. The center sees over 600 children and almost 200 adults per year, making it one of the busiest clinics in the world that is focused on Down syndrome. Dr. Vellody is the immediate past president, first physician president in almost 50 years, of the National Down Syndrome Congress, and is co-chair of the Professional Advisory Council. He has spoken at a variety of local, regional, national, and international meetings on the care of children with Down syndrome. And Dr. Vellody became a pediatrician in large part because of his relationship with his older brother, Das, who is smart, funny, caring, and also has Down syndrome. So Kishore, welcome to the podcast. Thanks for joining us.
I'm so glad to be here, Tony. It's great to walk the couple of doors down to be able to join you for this podcast.
Yep, Kishore is one of my partners and 2 doors down, and I'm going to tell a story along those lines. For those of you listening, if you're listening to the podcast and you're a fan of the podcast at all, you have Dr. Vellody to thank. Because I remember back in 2016, I had this idea for a podcast, and I have never, I'd never had any experience in a podcast before, but I know the Down Syndrome Center of Western Pennsylvania has a podcast, and Kishore is the host of that, where they talk to parents about different topics related to Down syndrome, the medical issues with children with Down syndrome, and other issues with children with Down syndrome. And I went over there and I said, how do you do this? And we talked for a while about audio editing and how to get your podcast on an RSS feed. So all of what I started knowing before I learned more came from Kishore. So Kishore, thanks for that.
Hey, I'm glad to have kicked off my second favorite podcast, which is PHM for Pittsburgh, because my own Down Syndrome Center of Western Pennsylvania podcast is my favorite. I'm sorry, Tony.
Of course. I understand. I understand. And now, Kishore, here's a question I want to start with. First we should do our disclosures.
Sure.
I'll go first, then I'll kick it out to you. I have nothing to disclose.
I have nothing to disclose.
And just as a courtesy to all those listening, remember there is free CME associated with this podcast. All you have to do is click on the link in the bottom of the description, and it's courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. So, Kishore, let's get into this. I want to start, before we get into specifics, which we're going to get into, tell me in general terms, what is it about Down syndrome that makes this episode necessary for inpatient pediatrics?
Yeah, I think much of what we think about when we think about Down syndrome often relates to a lot of the outpatient guidelines that exist. How often should we check thyroid levels? When do they need to have their hearing screened? When do they follow up with their cardiologist? Those types of things. But then one thing that really has struck me over the years is how unique it is, the care for children with Down syndrome in the hospital setting for a variety of reasons. And I'm sure we're going to get into a lot of those more specifically during this podcast. But, anyone who's a hospitalist knows that when October, November rolls around, we start to see a lot more admissions into the hospital with kids with Down syndrome, most of the time respiratory related. And we have to ask ourselves, well, why? And how can we provide the care to those children better and more specifically for what it is that they are dealing with?
Well, then let's start at the beginning, if you don't mind, which is birth for these kids. Now, 50% of hospitalists, those listening, take care of newborns at birth. So first, let's start out with numbers, some numbers. What percentage of children born with Down syndrome are born as a surprise to the family, meaning there wasn't nobody knew, there wasn't planning, they didn't come see you in the clinic before?
Yeah, that's a rapidly changing number right now, Tony. And it's a great question because when I first took over the Down Syndrome Center here about 11 years ago now, we would tell people about 80 to 85% of the time people would find out after the baby was born, mainly because the screening tests back then really didn't have great sensitivity or specificity. And so you could kind of get a sense, but not really. The quad screens are only so good. Within the last 5 years or so, the non-invasive prenatal screening has really taken a much greater role in obstetric care for people. And so for those of you who are not familiar with this, this is where you take mom's blood, and while she's pregnant, you can gauge whether or not there are any cells in her blood that have an extra chromosome 21. And presumably if that was there, that would be because of transplacental transfer from the baby within her into her bloodstream. And so that test in the right prevalence group can have an incredibly high positive predictive value for diagnosing Down syndrome prenatally. And so it's something that's changing. So now we would probably say, I would say just in my own just thinking about it, probably about 50% of the time, people actually already know or suspect highly prenatally, which is a dramatic difference in the last 10 years.
And just to recap the prevalence of this, now what I have read is this is the most prevalent genetic anomaly there is, and it's about 1 in 700 children are born with Down syndrome. Is that right?
That's correct. There's about 1 in 700, according to the CDC, about 1 in 700 live births will have Down syndrome.
So now if I'm a hospitalist and I'm taking care of a child, they're born, and I think before we get into why I should think they have Down syndrome, but I think they have Down syndrome, I feel like this could go one of two ways. Either go really well with the family or not go so well. And a lot of that depends on how we deliver the news, what we say, how we react. So my question to you, and maybe it's a little skewed here, because again, your center is so active. I know I rarely have to do anything with my Down syndrome patients ever because I know your center's on top of everything. But who's the best person to deliver the news? How should we deliver the news of a child is born to a family that did not expect it and the child has Down syndrome? What should we do?
Yeah, there's some really great papers out there that we can find. In fact, even just about 2 years ago in Pediatrics, they had a really great, maybe 3-4 page article about how best to deliver the diagnosis with a little table with a diagram, which would make it very easy to have on hand, maybe on your phone even, when you're going in to make a diagnosis like this or to share a diagnosis like this with the family. It's so important. Our word choices are remembered very much like what they call a flashbulb memory for the families. They do remember with incredible accuracy, even years later, how they were told because of the emotions that are wrapped up within that. And so it's so important that we do this well, and we do this in a way that serves the families best. So there's been some really great studies that look into how to share the diagnosis. The best person to give the diagnosis is the one who can find themselves to be fairly knowledgeable about Down syndrome and currently knowledgeable about Down syndrome. Many of our families will say, yeah, the doctor came in and they said that our child would never walk, never talk, never go to school, and would forever, live in our home. And that might have been accurate in 1940. But it's certainly not accurate today in 2020. And so it's got to be somebody who's knowledgeable about Down syndrome, and as soon as possible, really, to share that news with the family. Not in the delivery room, of course, but when things are calmed down from the delivery process, once that first suspicion is there, so important for a person to go in there and share that information that I suspect that your child has Down syndrome. Because what the studies have shown is that most of the time the parents do know that there's something up. They can see the doctors whispering to each other. They can see the nurses not entering the room with the same level of joy that perhaps they remembered from prior births and things like that. So important to do that as soon as possible. And then to give the information that's important in that moment. To say, hey, I suspect Down syndrome, and we're going to do X, Y, and Z to confirm that diagnosis and do other early newborn testing that's required, but not to go into, and when your child is 50, they might have Alzheimer. Like, that's not necessary in that newborn period. And I think it's important to tailor our discussions for the moment that we find ourselves in. There's so much more I could go into. I don't want to do it all right now unless there's like specific questions, Tony, that you want me to address.
Well, what phrasing is wrong? What should we not say? If we're going to deliver this news, what are things we shouldn't say to the family? And besides, your child may have Alzheimer's at 50 years old or could have lymphoma when they're older or something.
Our word choices are so important in that even without necessarily saying something with direct words, we're actually saying it perhaps in the way that we phrase things. So things that we want to avoid, you don't want to say, oh, your child suffers from Down syndrome. It's inaccurate, first of all. That even when you do self-surveys of people with Down syndrome, 99% of them will have said that they are happy with who they are and they wouldn't change a thing about themselves. Now, Tony, in our own call right now, I bet you we wouldn't get to a 99% between the two of us, right? Yeah. There are things that we always are like, oh, I wish I was different or better. But people with Down syndrome don't feel like they're suffering from anything. I think even words like normal, compared to normal kids, your child will, X, Y, Z. The word normal is got a lot of baggage with it. And I think that it's important to recognize that child with Down syndrome also is normal. They just happen to have Down syndrome, but they're human just like we are. And I think that's an important thing to keep in mind. We want to avoid labeling the child with the diagnosis. Like we go on rounds on hospital medicine, Tony, we don't want to say, the pneumonia kid. Right. Similarly, you don't want to say, oh, the Downs kid, or your child is a Downs, because that is incredibly painful to a family to hear their child labeled with a diagnosis before being told that they're a child first. So we talk a lot about using people first language. First you say a child, then you say with Down syndrome. So the first thing that you call them is what they are, which is a person or a child, but you don't open up with labeling them with a diagnosis. We certainly want to avoid overgeneralizations as well. So you go in to meet a new mom and you say, oh, I think your child has Down syndrome. And I just love all kids with Down syndrome. They're all so happy and they all love hugs. Like, those kinds of overgeneralization suddenly takes your child, who's your baby that you've been waiting for 9-10 months most of the time, and now makes them just, again, overgeneralized to a particular diagnosis. And lastly, I want to make sure that we use up-to-date language. So we don't use terms like mentally retarded anymore, mainly because retarded has become such a negative word. In fact, within our Down syndrome community, we call it the R word. We don't use that word because while it once might have had a medical connotation, it now has more of a derogatory connotation in the general public. So instead, we might say something like intellectually disabled or differently abled is another way that people will sometimes talk about things. And so we again, very, very cautious about the word choices that we use with the families.
And so what I would say if I were in the room, I would let them know your child has Down syndrome. We can get into the specifics of what that means, but for now, if they are healthy, because some kids are born with cardiac issues, et cetera, that require immediate attention. But if they are healthy and fine, I would say they're doing very well. They're healthy and fine for now. That's what we're thinking. Now, here's my next question. A lot of people, when you're on rounds, get into I was going to ask this later, but I'm going to move it up now. They're uncomfortable, especially residents, diagnosing a child with Down syndrome because they feel like they need a genetic test to prove it's Down syndrome because they're uncomfortable in their skills. They're new. Is it true? Do you need a genetic test? Is it a clinical diagnosis? Is it both now? What should we be doing?
Yeah, it's so important to, at the first moment of clinical suspicion, and as we're going to talk about, I'm sure you're going to see some different physical exam findings, and you're going to say, gosh, I really do think that this child has Down syndrome. what the families say in all of these surveys is, we want to know as soon as you're suspecting it. We don't want to wait for a week, or sometimes some hospital systems up to 2 weeks to get a karyotype chromosome testing back. They want to know when you're suspecting it, because otherwise the question then becomes, well, why are they hiding this from me? What is it that's so bad about Down syndrome that they didn't even feel like they should say, oh, I'm wondering about whether that might be, right? If you hear a heart murmur, even on a baby without Down syndrome, you hear a heart murmur, most of the time as hospitalists will be like, I hear a heart murmur. Has anyone else ever heard that before? And maybe we should get an echo or an EKG. And that same way, like when we're looking at a child and we're like, I think this baby has Down syndrome, it's the best thing you can do is to tell them when you first suspect it. But then you do want to send confirmatory testing. Sometimes you might say, well, why do I need confirmatory testing? I've been doing this long enough. I can tell when a child has Down syndrome, especially when they have so many features. And the reason is we want to know what type of Down syndrome the child has, because as you all remember from your genetics class as medical students, there's 3 main ways that you can have Down syndrome. One would be straight trisomy 21, where every cell in the body has an extra chromosome 21, and that's about 95% of the time what we see. But then about 3 to 4% of the time you can have translocation type, and you might remember the word like Robertsonian translocation. That's when you have usually chromosome 21 attached to chromosome 14, but sometimes you can have 21 attached to 21. And the reason it's important to know that is to know that type can have a higher chance of being found in the parent as well. So one of the parents might carry that translocation, which means that they might have a higher chance of having future children with Down syndrome. So from a genetic counseling perspective, knowing that the baby has translocation type will often lead to an offer to the family, to the parents, to get their chromosomes checked as well. And then lastly, of course, there's mosaic type, which is very interesting and still to this day not so completely understood. It's less than 1% of the time where some of the cells will have trisomy 21 and some won't. And that can lead to, of course, a variety of different phenotypic and, of course, developmental outcomes as well. So yeah, really important to send that karyotype, but also equally important to tell the family that you're suspecting Down syndrome. And we've had many times where the newborn nursery will call us because we have a really great relationship with our local birthing centers, and they'll say, we're not sure, we think this baby has Down syndrome. Would someone from your center like to come by and meet this family before they go home? And we're glad, and we'll go and we'll give them all the information about Down syndrome. And then I've had it where a week later the karyotype comes back and the baby doesn't have Down syndrome. And guess what? It's okay. I call the family and I'm like, guess what? Your baby doesn't have Down syndrome. And they breathe a sigh of relief because they were expecting perhaps to have a different course, and now they realize that they don't. And so it's okay to suspect something and then find out later that, okay, we were wrong.
They never get mad at you when you call them and say, no, you guys scared us all this much.
No, in fact, every parent that we've had that situation with has approached it with, I'm so glad we got to meet you, and I'm so glad we got to learn about what you do in this area. And we're also glad that our baby is not, doesn't have to have a lot of the concerns that perhaps we would have had if they had Down syndrome.
Okay. Now, since we've talked about being suspicious of it and wondering if it looks like if patient looks like they have Down syndrome, let's talk about some of those physical exam findings in the newborn period that would make us suspect it. And for those of you listening at home, I know some of you have been hospitals for years, so some of this may be review, but there's no harm in review, just to kind of go over some of the major and some of the minor features so we are all on the same page.
Yeah. I mean, the most common thing that you're going to see in any baby, almost every baby with Down syndrome, is hypotonia. 99% or more will have hypotonia, and beyond what you typically would see in a baby, right? We all know when you handle a baby, you got to be pretty careful because they're pretty floppy. But in babies with Down syndrome, it's quite significant. And when we feel that, it's a striking thing. Facial features wise, things that we can commonly see would be slanted palpebral fissures, depending on which side you're starting with, either up slanting or down slanting, palpebral fissures. So the eyes will have that characteristic look. Also epicanthal folds, which are the skin folds on the medial side of the eye, can be seen in people with Down syndrome. Their eyes themselves can also have what are called brush field spots, which are very easy to see in a baby with light colored eyes, so blue eyes, maybe light brown eyes. You can see these little stars almost that form a circle around their iris, and that is has no visual consequence, but it's just something that is commonly seen in people with Down syndrome. The nasal bridge tends to be a little bit flatter, so we do see that quite frequently. Head shape also we can see more commonly brachycephaly, which is diffuse flattening of the back of the head. So not necessarily plagiocephaly, where, as we know, where one side of the head gets flattened because of usually positional things, but brachycephaly, which is just the way that the skull shape is, where it's flat on both sides of the occiput in the back. We see some looser skin often in the nape of the neck. And we can, so far as extremity findings, a single palmar crease is quite common, and also clinodactyly, which is an incurvature, usually of the fifth digit. Those are some of the more common physical exam features that we'll see.
What about the space between the toes?
Yeah, that's a great thing. Yeah, sorry. Yeah, and also what we would look at maybe is kind of a extra space between the first and the second toe, which has almost like when they're wearing like a thong sandal or something, like that space between that toe. We definitely will see that more commonly in the babies as well.
So if I'm examining a baby and I'm thinking, I feel like this kid's a little hypotonic, I'm going to do my slip through test and my U test. And then if they're positive, then I'm going to begin looking at the other characteristics from head down, looking for signs of Down syndrome. And is there a number you look for? If there's 2 or 3, you're thinking, I'm suspicious now. So then I'm going to begin talking to the family, begin sending testing.
Yeah, I agree with you. It's one isolated finding alone doesn't mean that you have to say, oh, there's a single palmar crease in this baby. That means they must have Down syndrome. That's not the case at all. You're right. It's just like any other syndrome. If you start to see more of a constellation of findings, you're like, oh, wow, look at that. Now there's 3 different features that I'm seeing. That would be the time to say, I'm going to send off confirmatory testing, talk to the family, things like that.
All right, so now we've diagnosed it, or we're suspicious of it. We've spoken to the family. Can we review some of the common organ system abnormalities associated with Down syndrome that could cause you issues at birth? Yeah. I know we know about the cardiac issues, or we can talk about those for certain. And then there's always the board question of duodenal atresia that comes up on every board ever. But others those and others that can cause you issues at birth where child may need immediate attention.
Definitely. And I'm going to get to that in just a second. I want to make sure before we leave the sending of the chromosome karyotype testing that we talk about the FISH analysis, which many of us are probably able to send very quickly from our newborn nurseries, will come back usually within 24 hours in most major medical institutions. That FISH analysis will only tell you that they have an extra chromosome 21. But it will not tell us which type of Down syndrome they have. So it's really important to have a karyotype sent on everyone, even if the FISH comes back positive, because we don't know what type unless we send the karyotype.
Will the FISH be positive for the Robertsonian translocation and the mosaicism you were talking about? Or
it'll show that there's extra 21st chromosome material, so you'll know the child has Down syndrome, but you won't know that they have a translocation until you send a karyotype.
Okay. Yeah. And for the reasons you already stated, it's important to get that to know which reason.
Exactly, and to know what type of counseling we might need to give to the family regarding future pregnancies. But yeah, you're right on. The board question. The number one thing we all think about when we think about Down syndrome is cardiac. At least 50% of people with Down syndrome will be born with some sort of anatomic cardiac defect. Now, does that mean that all of them need to have surgery? No. Some of them might have an isolated ASD or an isolated VSD that might close on their own or might never give them any trouble in their whole life. So that's included in that 50% number. But then a much larger number than we would expect in the general population will have what's called an atrioventricular septal defect, or otherwise known as an endocardial cushion defect. Or AV canal defect you might hear as well. All of those are meaning the exact same thing. And so, of course, in an AV septal defect, you're going to need to have surgery at some point to have long-term life. And so usually that surgery is delayed until they're a little bit older for technical reasons. When the babies tend to have higher pressures in their lungs, higher pulmonary hypertension, And so to do a cardiac surgery in the newborn period is really hard in a lot of babies, especially babies with Down syndrome. But also just technically that it's a smaller space to do a big surgery. And so you need to wait till they're usually 4 to 6 months of age. But yeah, AVSDs are really common. We also see tetralogy of Fallot at a higher rate as well. Aortic arch abnormalities like coarctations and things like that. Sometimes in combination, we can see some of these things. So yeah, very important for us to consider cardiac issues. And GI defects, just like you're describing, babies with suspected Down syndrome who are vomiting, particularly if they're having bilious vomiting in the newborn nursery, we have to rule out an anatomic obstruction. And really, anywhere from mouth to anus, babies with Down syndrome can have obstructions. So pyloric stenosis happens more frequently, tracheoesophageal fistulas happen. But you're right, duodenal atresia is the classic PEDS boards question that you're going to see. And typically in that situation, you would see the double bubble sign where the air, the gas doesn't pass beyond the first part of the duodenum. So in a distended belly, baby who's vomiting, you would definitely want to think about duodenal atresia, duodenal stenosis as well. In fact, if you were to see either of the two we've talked about so far, AVSDs or duodenal atresia, you should probably be sending a karyotype 2 because those are so classically associated with Down syndrome that it would be important to make sure, even if you're thinking phenotypically they may not have Down syndrome, they might have mosaic type or something, because these two features are so classically associated with Down syndrome. Hirschsprung disease, annular pancreas, imperforate anus, we see all of those things in babies with Down syndrome. So that's important. Other newborn things that we want to make sure as part of the normal newborn screen, I think in all 50 states, we would send a thyroid function study. Depending on the state in which you find yourself, though, and Pennsylvania is one of those states where we are, Tony, is that they only send a thyroxine level here. And in babies with Down syndrome, they can maintain a normal thyroxine level and have TSHs in the hundreds. And so it's really important that every baby with Down syndrome when they're born has a TSH sent, whether it's on the newborn screen in your state or whether it's a separate lab stick that you have to do in the newborn nursery. The other thing that we want to think about in newborns with Down syndrome is from a hematologic perspective. They can be born with transient myeloproliferative disorder, or TMD, which is, again, one of those very classic features that we would see pretty much only in babies with Down syndrome, where they are born with essentially leukemia. They have high white counts, low hemoglobins, low platelet counts, and they have immature cells all over. And it's pretty much an in utero leukemia. And the odd thing about transient myeloproliferative disorder is that it resolves on its own a dramatically high number of times without any type of chemotherapy. It's really strange. But the thing that we want to know is we want to send a CBC on every baby who's born with Down syndrome, because if they have that, they have a much higher risk of having acute myeloid leukemia in the first 3 years of life. And so we would watch them very closely for AML if they were born with transient myeloproliferative disorder. Even if it resolves on its own, we would want to pay close attention to that.
Is this someone, if you felt that their child was born, you send your CBC, you get the very high white count, low hemoglobin, low platelets, would you consult hematology oncology to follow that child in the newborn period with you?
Immediately. That child should go to the NICU, and if you don't have a NICU in your hospital setting, they should be transferred to a tertiary care center where they can, because the concern is that those white counts can get so high that they can actually start having vascular congestion because of it, and it can lead to some serious issues that way. And there are a certain percentage, about 20%, that will need chemotherapy. So yes, without a doubt, oncology will be an important friend. And long-term, for following these kids and looking at their smears, usually every 3 or 4 months in those first 3 years of life, to make sure that they don't develop AML.
So 20 to 30% of those kids born with it will need chemo in the newborn period, even though most do fine.
And most of them do fine and don't need any chemo, which is an incredibly strange thing to say when it comes to leukemia.
That is it. So now if I'm suspicious, now I've been suspicious of this child, they have 2 or 3 physical exam findings. Now I know I'm also going to do a very thorough cardiac exam. I'm going to send a CBC and a TSH, and I am going to look for signs of GI issues like vomiting, et cetera. And if I see any of that, I'm getting an x-ray or I'm doing other things looking for these things we're talking about.
Yeah.
And now I know if there's a CBC abnormality, what I have to do. What else you got?
You have to make sure, and this is again, I think, also in all 50 states, a newborn hearing screening
Mm.
is crucial for people with Down syndrome. Hearing loss is much more common in Down syndrome, and so, especially, and they can be born with it at a higher rate, and it could be conductive, it could be sensory neural, and so, of course, we want to make sure that they get their newborn hearing screen. If they don't pass it, that can be challenging because a lot of children with Down syndrome have very narrow external auditory meatuses, and so they can't necessarily tell whether the failed newborn hearing screen is because the OAE never got to the eardrum or not. So they need to be rescreened. If they have a hearing loss, they need to be rescreened within the first 2 months after they leave the newborn nursery.
Okay.
Yeah. Those are the big newborn things I'm thinking about in people with Down syndrome.
Well, that sounds good. One of the topics I do want to talk about during our time, I'm pulling up my list of questions right now. One of the things I've noticed being a hospital taking care of children who have Down syndrome is, especially during peak respiratory season, if they come in with any type of bronchiolitis or respiratory illness, I noticed off the bat they almost are always hypoxic, and they are very hard to get weaned off of oxygen. So I did some reading to prepare for this podcast episode, and for those of you listening at home, here's the articles I went through. RSV Gold Study Group, Respiratory Syncytial Virus Related Death in Children with Down Syndrome, the RSV Gold Study. That's in Pediatric Infectious Disease in 2020 of August, volume 39. And I also read Down Syndrome, a novel risk factor for respiratory syncytial virus bronchiolitis, a prospective birth cohort study. That's in Pediatrics in 2007 of October. That's by Bloomers et al. And then by McDowell et al., Pulmonary Complications of Down Syndrome During Childhood, Journal of Pediatrics, 2011, February. And they kind of reinforce what I've seen is that kids with Down syndrome have a harder time with respiratory illnesses. And from what I read, RSV, they're actually putting aside their cardiac complications that they can have because of Down syndrome, which make RSV more difficult. They are at an increased risk of death due to RSV in general. Is that correct?
You're correct. Yeah. And this is where it beautifully merges together my two roles. One is a hospitalist and one is running this Down syndrome center. Is October, November, typically, when we're in a typical respiratory season, we start to see a ton of kids coming in from our clinic. And the reasoning, well, what the studies have shown is that just statistically alone, kids with Down syndrome are more likely to have symptomatic bronchiolitis. They're more likely to come and be admitted to a hospital. They're more likely, when admitted, to be in an ICU setting. And they're more likely to spend longer number of days and require more supplemental oxygen than age-related peers. And so there's something specific to Down syndrome. Now, when you think about from a pathology perspective, when you look at the lungs of people with Down syndrome, they do seem to have fewer alveoli than other kids at the same age. And so perhaps there's something about the alveoli being filled up with mucus, as we know always happens with bronchiolitis, that might be part of the reason why they seem to deset so much when they come in with their respiratory illnesses. But the one thing that we also know is that people with Down syndrome have an altered immune response just on the basis of having Down syndrome alone. So their response to viral triggers, RSV and influenza included as well, they seem to have a response that results in more lung damage and less killing of the virus than we would see in other kids. The other thing that we see is that the immune system, particularly for encapsulated organisms like pneumococcus, is not as effective in people with Down syndrome. And so a couple of things that this brings up. One is there have been several studies that have come out in the last few years, and I don't know how much this might impact our upcoming Down syndrome healthcare guidelines when they get updated, but it seems that Down syndrome alone is a risk factor for severe RSV disease, to the point that some people are advocating for Synagis universally for people with Down syndrome, regardless of whether they have any cardiac or respiratory or prematurity related reasons to get Synagis. The other part of it is, from an immunization perspective, is that already the guidelines call for all children with Down syndrome with a cardiac or respiratory known condition, they should all get Pneumovax or PPS 23, in addition to Prevnar. because it increases their ability to have an immune response to pneumococcus. And so there are also a subset of people who are saying we should just universally be giving people with Down syndrome pneumovax as well. And so there's a lot that's probably going to be changing here in the next several years. We have to think about it from a cost-benefit perspective, of course, too. Synagis is not cheap, palivizumab, not cheap. And so, but also hospitalization and ICU stays and long stays in an institution are also not cheap. And so you have to figure out which one is the best way to go in terms of preventing these types of disease, perhaps in people with Down syndrome.
Do we know for certain the cause for these kids to have a worsening respiratory status? Because I've read different theories. Your immune theory is very, very common. I've read because 25% of kids with Down syndrome have ENT abnormalities, whether it's tracheobronchial malacia, subglottic stenosis, tracheal stenosis, or laryngomalacia. I've also read that there's an increased reflux, gastroesophageal reflux in kids with Down syndrome, where they think that plays a role. And then one of my questions is, we know kids with Down syndrome have a high percentage of obstructive sleep apnea, and how much of that plays a role in getting them off of oxygen, making it more difficult. Is this all still kind of being researched, or do we have more of an idea, or do we think all of this plays a role?
No, it all plays a role. And one more I would add to that list, Tony, would be swallow dysfunction. Because of the oral hypotonia, we see a lot of dysphagia, a lot of swallow dysfunction. And so all of that probably plays a role into why it takes so long for kids with Down syndrome to come off oxygen. Especially the older ones, Tony, we've talked about this before, is that, if you have a 4 or 5 year old who has Down syndrome and has been snoring and restless sleep and headaches in the morning and all the other things that we would think about with sleep apnea, and they get pneumonia, and clinically they're improving from their pneumonia, but they keep desatting, especially when they go to sleep, it may have absolutely nothing to do with the pneumonia. It just might be where they've always been because they've had sleep apnea that hasn't yet been addressed. And so nighttime desaturations may just be their baseline, which needs to be addressed through a sleep study and perhaps tonsillectomy, adenoidectomy if they have sleep apnea, all of those things. But yeah, the respiratory system is primed for significant difficulties with viral and bacterial pneumonias in Down syndrome for sure.
So what advice do you give hospitalists who have a child, let's say with bronchiolitis, under 2 years of age, maybe not RSV because that's more serious, any bronchiolitis, they have this infant, how do we get them off oxygen? Do we just use our standard techniques of really just waiting them out? What do we do?
Yeah. And that's a tough question, right? Because as we know from the hospitalist data alone, not even Down syndrome specifically, is that we are using pulse oximetry way too much, particularly continuous pulse oximetry way too much. And all it does is increase length of stay, increase costs, and all the things that we talk about on the hospitalist listserv all the time. And I think the same thing would apply to people with Down syndrome, right? We have to recognize that, like we were saying, many of the kids will likely have some baseline desaturations that we never would have known about had they not been admitted for their respiratory illness. And so it then becomes one of those things where it's like, what's my comfort level with this child? This is a happy, smiley kid. The mom says he snores all the time. I'm suspicious that he probably has had sleep apnea for a long time. I don't know that I would say just because he desats when he sleeps that I'm going to keep him in the hospital on a continuous pulse ox. I think I'll probably send them home, follow up with ENT or pulmonology, and have them get a sleep study down the road. In a kid with respiratory distress, all bets are off, right? It's a whole different story. If they're in respiratory distress and I'm finding that they need supplemental oxygen, well, I don't think it matters whether they have Down syndrome or they don't. If they're in distress, I need to manage that distress. But I think the times where I get called most often is, what do you think we should do with your patient from Down's clinic who it's been 5 days and he's happy and running around, but when he sleeps, he desats? I think that's a kid where we can safely assume that his body has probably been desatting for a long time and he needs to have that chronic issue addressed rather than doing something like supplemental O2 at home, which we all know in an obstructive pulmonary process could cause more harm than good if we're supplementing them with oxygen when they're chronic CO2 retainer.
So at what age would you recommend a child with Down syndrome get their first sleep study then? We're going to have these kids in the wintertime.
Yeah, it's a part of the AAP guidelines that all children with Down syndrome, regardless of symptoms, should have a sleep study done by the age of 4. If it's earlier than 4, if they're having significant snoring and it's a 2-year-old or something like that, then we'll get it done then. But at least by the age of 4. And even if their parent reports are asymptomatic, because one thing the studies have shown very clearly is that parent report is unreliable, particularly in Down syndrome. That the parents might say no signs of sleep apnea, but yet the child has significant sleep apnea. And the management of sleep apnea is going to be revolutionized here in the next few years as these studies are coming out. There's some really great things that are there. First step at this point is still tonsil and adenoid removal, which for the general pediatric population is like a 90-95% cure rate for sleep apnea. But in Down syndrome, it's only about 50% because they typically have multiple areas of airway obstruction. But then CPAP is the next step after that. And CPAP is very hard for children who have facial sensitivities, which a lot of people with Down syndrome do. But it used to be, okay, well, then we have nothing left other than trach or something horribly invasive like that. But there's a new thing, and actually Children's in Pittsburgh is part of this study that's come out, which is the hypoglossal nerve stimulator. It's being used in adults in general, but it hasn't been used in children, and certainly not in children with Down syndrome. So our institution is part of the group that's going to be using this. And essentially, it's a pacemaker for the base of the tongue. So when the child goes to sleep, the sensor senses when they inspire, which then pushes the tongue forward imperceptibly, pushes the base of the tongue forward, opens up the airway. And we have seen in these reported studies kids with apnea-hypopnea indexes in the hundreds who have been trached because of it, who now are able to be decannulated because of this device. And so it's going to probably be the biggest change ever, really, in the management of sleep apnea in people with Down syndrome.
Is this device implanted in the tongue, or where is it?
So it's implanted on the battery pack is implanted under the chest. The wires then lead under the chest and to the base of the tongue. And then there's respiratory sensors that are there in the chest that tell when the child takes an inspiration. And then it automatically at the same time sends an electrical signal to the base of the tongue to push it forward. It's imperceptible to the child because he's asleep.
Fascinating.
And it takes care of the multiple airways of airway obstruction that we know exist in people with Down syndrome, all in one fell swoop.
And with that, I mean, OSA unchecked always leads to a higher blood pressure and other issues, and especially kids with Down syndrome.
Mm-hmm.
I didn't know. That's fascinating.
It is, yeah.
Well, Kishore, these were all the questions I had for inpatient management of kids with Down syndrome. Was there something else we should have brought up that we didn't talk about?
I think we've touched on a lot of really great topics. I think one other area, particularly for our colleagues that are hospitalists that may deal with, ER consults or perhaps even participate in some trauma type events and things like that. I think it's important for us to just real quickly touch on atlantoaxial instability. There's been a lot of change in the way that we manage that and approach that. So atlantoaxial instability, for those who are not as familiar, of course, we remember the atlas and the axis, the first and second cervical vertebrae that are held together by ligaments, by the dens of C2, sticks up from C2 and it holds C1 in place, but allows rotation of the neck, which allows us to kind of look from left to right and side to side and things like that. Well, in people with Down syndrome, those ligaments that hold C1 to C2 can be lax, and so therefore there can be extra movement. And as we all know anatomically, the spinal cord also goes through the cervical canal. And so if there's excess movement of C1 on C2, you can get a cervical spine trauma. And of course, that's not good. And so for years, we used to do routine x-rays on people with Down syndrome, whether they had symptoms or not of atlantoaxial instability. And what we've discovered over the years is that those x-rays have extremely poor positive and negative predictive values. And so therefore, we're irradiating a whole lot of necks for really limited benefit. Because even if says it's normal, if the child's in a car accident or falls out of the bed or jumps off a trampoline and hits their head, these are things that can result in atlantoaxial instability and cervical spine damage, cervical spinal cord damage, which, of course, we would never want to have happen to anyone with Down syndrome. And so, like I said, the x-rays are not great. MRI is wonderful, but in order to do an MRI of a cervical spine, most of the time the kids need to be either sedated or under general anesthesia, which is also a huge risk to undertake in everybody with Down syndrome. So back in 2011, the healthcare guidelines changed to say, unless you see symptoms of atlantoaxial instability, which would be things like neck pain, neck stiffness, arm or leg weakness, change in the patellar reflexes, change in the way that they walk, loss of bowel or bladder control that they once had. If you see any of those upper motor neuron type findings, then all bets are off, and we should do a cervical spine X-ray to start and move more quickly to MRI most likely. But if they're asymptomatic, the guidelines said don't X-ray everybody anymore. And there was a lot of consternation about that. What's this going to mean? Are we going to have a bunch of kids coming in and have cervical spinal cord damage and we never would have known about until they have it? And actually what's shown is that in the last 10 years, we haven't seen any increase in atlantoaxial instability, even without doing routine x-rays. So x-rays only if symptomatic really does seem to work, and it's reduced the number of x-rays, which is wonderful for people with Down syndrome. But it is important, and the reason I bring this up to us is if you have a child, let's say our child we're talking about with respiratory distress, and they need to be intubated or something like that, it's probably great if you have some time to see if you can get some extra airway support with you. Maybe you have an anesthesiologist or someone who has some fiber optic ways of intubating someone who's had neck trauma with Down syndrome. It would be great, because the less you have to hyperextend the neck of somebody with Down syndrome, the better. And regardless of whether they've had a prior x-ray of their neck or not that said it was normal, you should treat every child with Down syndrome, particularly those that are unconscious from trauma or from anesthesia. You should treat them all as if they have atlantoaxial instability and move their neck as minimally as possible, particularly during airway maneuvers that's going to require hyperextension of the neck. And Tony, that reminds me of something else when we're talking about intubating. Remembering, all of us as hospitalists should remember that people with Down syndrome have much more narrowed airways than the rest of us. That's part of why they have all these respiratory issues we've been talking about today. And so when a child with Down syndrome perhaps needs to be intubated, we need to be cautious about the size of the endotracheal tube that we choose. You know, the equations that we use to calculate the endotracheal tube size, let's say it comes up, we say, oh, you need a 5.5 diameter endotracheal tube. For somebody with Down syndrome, you might actually need to go one size smaller or two sizes smaller. So you might need to go to a 5.0 or a 4.5 in somebody with Down syndrome, because they have such narrowed subglottic airways that tube may not go in if you try to do the regular calculations that you normally would use.
So two sizes smaller. Yeah. Try not to flex or maneuver the neck more than you need to. So ideally, if you have to intubate, you have somebody with fiber optic ability or a little bit more experience intubating kids who are more challenging, maybe an anesthesiologist, a pediatric anesthesiologist.
This would definitely not be an intubation you would want to give to the first-year resident or something like that. Okay. This is something where someone who's had some experience with intubating with minimal hyperextension would be the goal.
Okay. Yeah. Well, that sounds great. This was close to an hour. I think we talked about a lot, Kishore. Anything else?
Can I just add one last thing, Tony?
Of course.
I want to make sure, especially with you as a med-peds person, and I know we have a lot of med-peds listeners to this podcast as well, transitioning of care for people with Down syndrome is so important. When we have Dr. Andy McCormick, who I think has been on your podcast to talk about vascular anomalies, that's another hat that he wears, but making sure that we adequately transition people with Down syndrome from the pediatric to the adult side is a very important thing, and I think that's something that we definitely do spend a lot of time doing effectively, I hope, here through our center. And the other thing I want to make sure that people know is that the things that you take care of as an internal medicine doctor, you probably never will have to take care of in somebody with Down syndrome. So we don't see solid organ tumors in people with Down syndrome. They just don't seem to get them. We don't see atherosclerotic disease in people with Down syndrome. We don't see hypertension. We don't see coronary vascular accidents, strokes. We don't see those things in Down syndrome. Why? Nobody knows. There's something on that 21st chromosome when you get an extra gene product that somehow seems to be oncoprotective and protective against the things that you would see as an internist, you would see in almost all your patients, things like coronary vascular artery disease and things like that. We just don't see it in Down syndrome. So I say all this to say, we talk about the complications in people with Down syndrome a lot in medical circles, but it's important for us to remember that there's some mysteries that people with Down syndrome carry within their bodies that would make life better for all of us medically. And we have to remember that as we maybe even thank people with Down syndrome for these gifts that they're going to give us in the coming years, because the NIH is actively looking into these areas and how we could perhaps package it into a pill. So Tony, I could drink my soda and eat my nachos and whatever, and not get any of these problems that would come naturally from those lifestyle choices.
That would be something. That would be amazing. That would truly
Yeah,
be amazing.
yeah,
And it just goes to show you how little we still know about so many things that we think are so common, that
yeah,
there's still so much more to learn.
definitely.
Well, Kishore, I have really enjoyed this. Thank you for coming on. I really appreciate it.
I am so glad, Tony, to have been asked onto your podcast. It's been a long time coming, and I'm so glad to have been able to be on here today.
It was my pleasure.
Yeah.
Thank you very much.
Thank you for listening.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.